Hello everyone. We are going to start the new section of medicine, which is gastroenterology. Now we will be proceeding with the first chapter, which is diarrhea. So I want to ask you one question. What do you mean by diarrhea? So I'll be teaching the same thing, diarrhea. It is defined as if the stool water content is more than 200 ml per day, then it is referred to as diarrhea. But we generally don't use this term. We mostly use the Bristol chart for identification of diarrhea. Majoritarily, this Bristol chart is strict in the ward, or you will see it in the OPDs. So how we will compare? So there are 7 types of stools that we get to know here. For the number 6 stool and number 7, they are referred to as diarrhea. The number 6 is moderate diarrhea and the number 7 is severe diarrhea. What is the difference between those two? So the difference is the 6th number, it has very loose stool, but the water content as compared to the 7th is less in the 6th. And the first and the second type, they are referred to as constipation. If you see small balls or pellets, then it is very constipated. If you see lump pieces, then it is slightly constipated, not a major thing to look on. So next we'll move on to frequency chart. On the basis of frequency, we'll classify diarrheas into 3 types. First is acute diarrhea, second is persistent diarrhea, and third is chronic diarrhea. What do you mean by acute diarrhea? Acute means it will last for a short duration of time. If it lasts for less than 2 weeks, then it is called as acute diarrhea. If it lasts for from 2 weeks to 4 weeks, between these periods, it is called as persistent diarrhea. And the third is chronic diarrhea, which will move from more than 4 weeks. So before knowing about the diarrhea, we should know the normal physiological conditions, and then we will get to know what is the defect in that physiological conditions to identify this diarrhea. First of all, we'll go with the normal physiological condition. So here is the physiology of absorption. Everyone knows, we have learned this in physiology. I know this, that we have small intestine. There are presence of 4 layers in small intestine. First is the lumen, then there is mucosa, submucosa, muscularis, and post mucosal layer. So what happens now? Food gets into the lumen, then the food is majoritarily absorbed after breaking down into the small intestine. The majority absorption takes place with the help of and villi and crypt of lubricant, which helps in secretion of enzyme. So the macronutrients which are absorbed are fats, carbohydrates, and proteins. Fats is most calorific dense nutrition. It is the most specific nutrition. The fat, this we cannot digest this. Sorry, we can digest it, but we cannot absorb this directly. We have to break these fats into triglycerides plus fatty acid, and then it is converted into chylomicrons, and the process, it is a physiological and biochemical process that I won't be teaching here. You should learn that in physiology and biochemistry. So after that, the second most absorbed material is carbohydrate, and after that it is protein. So after looking at the absorption, physiology of absorption, we'll go towards the pathological viewpoint of this. Then here we see that we already see that on the basis of frequency, we have classified this diarrhea into 3 types, which is acute, persistent, and chronic. So we'll learn first the acute diarrhea. The acute diarrhea, it causes due to infection. Most common in adults, which is norovirus, and most common in children is rotavirus. These are the viruses which infects an individual. And this acute diarrhea is self-limiting. Self-limiting, what do you mean by self-limiting? Self-limiting means it will disappear its symptoms after 2 weeks, or before, within 2 weeks, the symptoms get disappear. So we can refer it as self-limiting. Second is chronic diarrhea. Chronic diarrhea, it can cause due to 3 reasons. First is osmosis, second is secretion, and third is inflammation. What is osmosis? Osmosis, everyone knows that if the water moves from lower solute concentration to higher solute concentration through a semi-permeable membrane, it is referred to as osmosis. So in osmosis, due to osmotic changes, there is malabsorption of carbohydrates, proteins, and fats. Majority of the fat is affected. So we can say that it is osmotic diarrhea. Due to secretion, if secretory diarrhea, due to presence of toxins, we know about the toxins. We have learned in microbiology toxin A, toxin B. We have learned whole section on toxins in this gram positive and gram negative bacteria. Second is tumors due to tumors. The tumor majority present here is lipoma. You know, oma term, it is referred to as, it is referred for tumors. Here is one note that what is malassimilation. Malassimilation, it is basically malabsorption plus maldigestion. If there is malabsorption and maldigestion, we will refer it as malassimilation. So pathological classification. First of all, I told you osmotic diarrhea. It is most consistent clinical symptom of malabsorption. If there is consistent malabsorption, it will lead to osmotic diarrhea. It is very crucial point, and the hallmark of osmotic diarrhea is steatorrhea. Steatorrhea is the hallmark of malabsorption, and it will lead to osmotic diarrhea. So what is steatorrhea? How you will define steatorrhea? Then passing of pale, bulky, fatty, malodorous, greasy stool. Malodorous means foul odor. Fatty stool, greasy stool, bulky, pale. Okay. It will refer to as steatorrhea, but the patient will come to you and he will not tell you that he is passing pale, bulky, malodorous, greasy stool. He will not tell you that. But if he tells that he observes oil droplet inside the stool, then you can get an inference that it is steatorrhea. The clinical representation of diarrhea. So the fact it is not absorbed in small intestine. This is the malabsorption that got inside the diarrhea. Now what happens? No, this fat is not absorbed inside the small intestine. Now it will move on to the large intestine. And in large intestine, what it will cause? It has fats, or not only fats, it will consist of carbohydrates and protein as well. Now in large intestine, you have accumulation of fat, carbohydrates and proteins. So it gets an higher solute concentration there. So obviously we know what is osmosis. The water will move from lower solute concentration gradient to higher solute concentration. So inside the lumen, there is higher solute concentration due to presence of fat and carbohydrate. And inside the cells of intestine, there is lower solute concentration. So the water will move from intestinal wall inside the lumen, and it will cause getting more than 200 ml per day. Then we will refer it as diarrhea. So here it is same thing that is written. If there is decreasing in fat absorption in small intestine, it will get passed into colon. Then unabsorbed micronutrients increases stool osmolarity. And when the stool osmolarity increases, it draws water from the large intestine, from the epithelial cells, and it will lead to osmotic diarrhea. So how you will identify that the person is suffering with osmotic diarrhea? For that investigation, we have 72 hours fecal fat test. It is a gold standard test. Here what you will do, no, you will feed the patient with 100 grams of fat for 5 days. Continuously you will feed him with 100 grams of fat, and you will start checking the stool from the third day. Here it is written. From day 3, day 4, day 5. These 3 days you should check the stool. If you get fat percentage more than 7 gram per day, then you will tell he is suffering from osmotic diarrhea. And if you didn't get, then the person is normal. Obviously is normal because he is not suffering from osmotic diarrhea. And if your investigation of osmotic diarrhea gets wrong, and if the person is suffering from more than 4 weeks, you should ask the patient that what is the duration you are suffering with diarrhea. He will come to you, he will tell you that I am suffering with diarrhea for more than 4 weeks. Okay, you get to know that it might be osmotic diarrhea. This fecal fat test, you saw that the fat percentage is fat is less than 7 gram per day. Now what you will do? you will move on to the next second investigation, secretory diarrhea. What is secretory diarrhea? Listen very carefully. Whenever you will find secretion inside your stool in a fasting stage, then you can say that you are suffering from secretory diarrhea. So that is the key mark that there should be presence of stool whenever you are fasting. There is no water inside your stomach. There is no food inside your stomach. Still, you are feeling defecation and water inside that defecation. So it is called as secretory diarrhea. And secretory diarrhea, it causes due to majoritarily due to two things. First is toxins and second is tumors. So in toxins, which are the organisms that are secreting that toxins are first enterotoxigenic E. coli and Vibrio cholerae. They are heat labile toxins. And then there is enteropathogenic virus such as rotavirus. What does this rotavirus do? This rotavirus affects children and causes diarrhea in them. Second is tumors. There are majority two types of tumors which are causing the secretory diarrhea. First is vipoma and second is gastrioma. I won't be writing this here. And the symptoms that are present when these tumors are present in the secretory diarrhea are, first is you will find watery diarrhea, second hypokalemia, and then acidosis. So it is also called as WDHA syndrome. Then the note. Note is very important. There is no structural damage seen in secretory diarrhea. If there is no structural damage, you won't see mucus, you won't see blood, you won't see any other substances inside the stool. You will see a clean stool, which has presence of water and electrolytes. That's it. So secretory diarrhea, we will be moving on to the comparison between secretory diarrhea as well as osmotic diarrhea. So in osmotic diarrhea, because of the presence of fat, it changes the osmolarity between the cells of the intestine and the material present inside the intestine, and it causes osmotic diarrhea. And so we will see what is the difference. The stool osmotic gap increases by more than 100 milliosmol per kg in osmotic diarrhea, and in secretory diarrhea it decreases or stays normal. It decreases less than 50 milliosmol per kg. And the electrolytes which are increased here is potassium and sodium. These electrolytes are increased with the help of toxins which are secreted by the bacteria, enterotoxigenic E. coli and the E. coli, Escherichia coli, and Vibrio cholerae. So the response to fasting. If you have done fasting, then there is no accumulation of fat inside the intestine, so osmotic diarrhea will be improved. But in case of secretory diarrhea, there will be no change in the secretory diarrhea because fasting does not improve the secretion of the electrolytes and water, which are done with the help of toxins and tumors. Stool pH. If it is less than 5.5, then you can say it is osmotic diarrhea. In osmotic diarrhea, generally it is less than 5.5. It is like slightly acidic because the carbohydrates which are fermented, they are converted into acids. So the pH decreases. Here you can see I have written fermentation of unabsorbed carbohydrate into acids. But in case of secretory diarrhea, it will stay slightly acidic or approximately neutral. So it will be more than 6. The pH will be more than 6. Note, what is osmotic gap? How do we calculate osmotic gap? So osmotic gap can be measured with the help of osmometer. Osmometer, we will be calculating osmolarity of the substance with the help of osmometer, and then we will be calculating the osmolarity with the help of formula, which is mass by volume, and then we will subtract the osmolality calculated with the help of measuring device and with which is calculated manually. We will subtract those osmolarity, and then we will get this stool osmolarity gap. So stool osmotic gap. So normal range, it is from 50 to 100 milliosmol per kg. And that's it about the secretory diarrhea. And then we will move to factitious diarrhea. Factitious diarrhea, it is generally caused due to some of the neurological disorders, or the patient might be pretending that it has diarrhea. Or third reason, if there is abuse of laxatives and purgatives, then it will cause factitious diarrhea. Often this is done by students who don't want to attend their schools, and they will do the same thing. We will discuss it later. And then this clinical representation, it is caused in adolescent female. It is a type of chronic diarrhea. There is fatigue and weight loss as well in this. Findings, how you will find that it is a factitious diarrhea or not. So you will collect a stool sample, you will get a stool analysis, you will find the osmolarity of the stool, and then you will get to know, okay, it is a diarrhea, it is a type of diarrhea. And there will be two types of stools that you will be collecting, which is supervised and unsupervised. If you collect an unsupervised stool and you got that the osmolarity is very low, look here, like it is very low, it is approximately 60 milliosmol per kg. If the osmolarity is very low, then you can get a suspicion that, okay, how this down that the osmolarity have been gone. So the patient, what they will do, they will pour tap water inside the stool sample, and you will get a very low osmolarity, because the osmolarity of tap water is very less. It is like 0 to 5 milliosmol per kg. So you'll find that in unsupervised stool you are getting very low osmolarity, and so you are getting misfindings. But when you are doing this supervised stool sample taking, so the osmolarity becomes suddenly normal. It will be like 270 to 290 milliosmol per kg. Then you can say that, okay, it is a factitious diarrhea. They might be pretending, or they might have some neurological disorder, that they are not ill, but they are thinking they are ill, and they are making the findings fluctuate in such a way that you also will think that they might be ill, but we are doctors. Now, this is anatomical classification. On the basis of anatomy, we can classify diarrhea into two types: small intestinal diarrhea and large intestinal diarrhea. So, I'll give you a trick for this: what is small intestinal and what is large intestinal diarrhea. In small intestinal diarrhea, large and clean. You just remember this thing: large and clean in small intestinal diarrhea, that you will get a large amount of defecation and it will be clean. And in large intestinal diarrhea, it will be small and dirty. Small and dirty, it means you will get frequent defecation. You will pass a small amount of stool, you will get the stool very frequently, and it will be dirty. Dirty in the sense that it will contain pus, it will contain blood, it will contain mucus. So with this trick, you can remember this. In small intestine, there might be osmotic diarrhea, there might be secretory diarrhea. And secretory diarrhea, enterotoxinic E. coli and Vibrio cholerae, they are the organisms which have been causing this small intestinal secretory diarrhea. Then in large intestinal diarrhea, invasive organisms such as Shigella. So there are invasive organisms. So practically, you will see if there is invasion, there will be a loss of blood and there will be loss of pus. So naturally, you will find this blood and pus inside your stool. And it may be due to inflammation, ulcerative colitis, and perforation inside the large intestine due to these organisms. Here you can see large amount of volume is dumped in small intestine. I told you the trick, that large and clean. Large means large amount of stool is dumped, and in large intestine, small amount of stool is dumped. Small and dirty, and both will have the watery consistency. That is the common point in them. The urgency in the small intestine will be less. You will like retain the stool and then you will pass it out with a large amount of water. So the frequency will be less, and here the frequency will be more. The pus and blood mucus, they will be more in large intestine, they will be not present in small intestine. Tenesmus and diarrhea, they both are present in large intestine. What is tenesmus? This, you will have the feeling that you should defecate, like you will have frequent feeling of defecation. So that is tenesmus. And in dysphagia, you will be like constipated. You will go and you have to push the stool out, and still it is not coming out. So that is dysphagia. Both are present in large intestinal diarrhea, but they are not present in small intestinal diarrhea. So in small intestinal diarrhea, there is no invasion, so there will be no abdominal pain, there will be no fever. There is invasion in large intestine, so there will be presence of pain, abdominal pain, there will be presence of fever. Bloating, gas formation, it will be present in small intestine, it will be present in large intestine, because most of the stool is staying there. Fermentation processes are also happening with the same time, so bloating will be obviously present there. Abdominal cramps, it is present in both. Weight loss, vomiting, they both are rare. They might be present, and if weight loss is present in small intestinal diarrhea, it will be persistent. And steatorrhea, it is hallmark, and it is present in small intestinal diarrhea, but it is absent in large intestinal diarrhea. What is steatorrhea? I have discussed it above in the lecture, that it is passing of bulky, greasy stool. So that is steatorrhea. Okay, this is a very important table. Listen very carefully because this will really help you in the diagnosis of the patient. So whenever the patient comes to you, what you will do, what will be your first question? So you'll ask from how many days you are suffering. What is the duration that you are suffering this diarrhea, these symptoms of diarrhea? If he says less than 2 weeks, okay, you can like think. If he's saying less than 2 weeks, it means it might be due to infection. It might be acute diarrhea and it is due to infection. Acute diarrhea is always due to infection. The infection might be in small intestine or large intestine. Now, what question should you ask? Okay, it is infectious, that is confirmed, but it is in small intestine or large intestine. So the next question you will be asking that what are the findings inside your stool? Do you find pus? Do you find mucus? Do you find blood inside your stool? If he says yes, okay, then you got a confirmed diagnosis that it is a large intestinal diarrhea. Here you can see fever, pain in abdomen, blood and mucus. Then it is large intestinal diarrhea. And then you can give drugs according to the organism which are affecting the large intestine, such as Shigella, non-typhoid Salmonella, and Campylobacter. So this is how you find large intestinal diarrhea. And if he says no, I don't see any pus, stool, I don't have abdominal pain, I don't have fever. So where you will go? You will shift on to the finding of small intestinal diarrhea. Then you will ask, do you pass large amount of stool and the frequency of passing stool is less? So you will say yes. Then you can get an inference that it is small intestinal diarrhea because large volume is passed in, but the frequency of passing it is less. Like the patient will go, now he will go, and after 10 minutes, 15 minutes, he will get the feeling of defecation. That is not too frequent. And in large intestine, like 5 minutes, they will get the frequency of defecation. So if you find that it is small intestinal diarrhea, you will say that it is caused due to enterotoxigenic E. coli or cholera, and it is self-limiting. So the symptoms will stop after 2 weeks. It is no doubt in that. Now the patient came and he told you he's suffering from diarrhea, but the duration of suffering is more than 4 weeks. So you will get an inference that okay, it might be chronic diarrhea because he's suffering from more than 4 weeks. Now you will think he is suffering from chronic diarrhea for more than 4 weeks, but whether it is small intestinal diarrhea or whether it is large intestinal diarrhea. So how you will find? It is small intestinal or large intestinal diarrhea. For finding this, you will ask the patient, do you find inflammation? Do you get irritation? Do you get fever, abdominal pain? If he says yes, okay, it is a large intestinal diarrhea, you will say ulcerative colitis. So there will be blood, pain, a lot of suffering there. But in small intestinal diarrhea, there will be not large amount of suffering. Now in small intestinal diarrhea, if you get to know, okay, he has no blood in stool, no pus, there is no ulcerative colitis. Now you will say he has small intestinal diarrhea. But in small intestinal diarrhea, which type of diarrhea? Whether it is osmotic, whether it is secretory. So first you will go for finding osmotic diarrhea. Now you will ask, okay, if you are not eating, you are not drinking anything, then what are the symptoms you are getting inside your report? So you will say, okay, I am on fasting. So if I am fasting in the night, I am getting no defecation. Then you can get an inference he is suffering from osmotic diarrhea because whenever he is fasting, the symptoms are getting reduced. So here it is written, if increased stool osmotic gaps improves on fasting. If it improves on fasting, then you can say it is osmotic diarrhea. If it doesn't improve on fasting, what will be your inference? Your inference will be secretory diarrhea. And secretory diarrhea, it causes due to vyphoma. If it is more than 4 weeks, obviously it causes due to vyphoma or gastrioma.